around my mother's end-of-life care. My mother was a Holocaust survivor, and she was the most optimistic, positive, upbeat person I've ever met. She was 21 years old when the Holocaust broke, when the Nazis invaded, in fact, right into her town across the River San into Przemysl, which is now in the Ukraine, on the border with the Ukraine. And so she lived for 6 years under Nazi regime until liberation in 1945, survived all by herself, the only survivor of her family, 2 parents that were in their early 50s and 7 siblings. The way that my mother survived and the way that she lived all her life afterwards, as I observed it, was her adaptation was really being very resilient, very competent. I can do it all by myself. Whenever she had a terrible health crisis or something terrible happened in the family, which a few times it did, she would say to me, I tell myself in my head, let's imagine that I'm in the war by myself. And she drew strength from that to face whatever she needed to. She was also very optimistic, always smiling, met the world with a great deal of optimism and generosity, and she said, that's what saved my life. And I saw it indeed. I saw how people were always inclined to, drawn to her and drawn to be helpful to her because that's the way she was and that's the way they were back to her. It was particularly painful, therefore, to see this woman have the most horrific death in what was really the ultimate failure of empathy towards her and towards the people who loved her, us. And the reason why I find it so important to talk about is because, there was a very important, this is a small tangent. Last week came the report of the Lancet Commission on Palliative Care and Pain Relief, speaking about the need to bridge the abyss in access to palliative care and pain relief all over the world, because there are many places where it's almost inaccessible to people. But it is also the case that in many countries, high-income countries like Israel, where my mother lived, and other places, I'm sure here, where good medical services exist, and nonetheless access to palliative and pain relief services is still problematic. And even places where these services, good palliative and pain relief services exist, there is often a very vehement and passionate disagreement about how to use them at end-of-life care. So my mother died in one of Israel's premier hospitals, a hospital that we were very familiar with because of many previous health crises, a hospital that saved her life in many previous times. But on this occasion, as she was, what happened was my mother was 3 days shy of being 93 years old when she fell at home and broke her hip. A very common accident in the old, and a very common cause of death. So it wasn't some rare disease that my mother was dying from. She was completely lucid and completely with it. And so because of her other health conditions, a consultation was called with a cardiologist and an anesthesiologist who told her she might not be able to breathe on her own after surgery. At that point, my mother said, no, thank you. I've had enough. And she decided to die. However, no palliative care and no pain relief care was offered. And therefore, when I arrived from the States directly to the hospital, and I saw her in the night. She was, In the morning, it was terrible. And when I asked the physician to give her some palliative care, he said to me, those were his words, and she was having a great difficulty breathing. There is no pain medication for breathing. We don't give anything for difficulties breathing. And there's no mercy killing in this hospital. And so I said, I'm not asking for mercy killing. I'm asking for palliative care to help her. And he got very agitated and said, I have my license, I have my faith, and I have my studies, and that's the way it's going to be. And at that point, you know, this is really a prime example of what the Lancet Commission speaks of when they talk about opiophobia, which is a combination of prejudice and misinformation about the appropriate use of medication in end-of-life care. So what I'm saying is there are a lot of things that go into end-of-life care, which go even beyond the guidelines that are written somewhere, because Israel does participate in agreements that member states participate in with WHO, and does have all kinds of things in place. And still, there is a lot that we need to do in order to, as a society, make it a very high priority for people, for multidisciplinary groups to get together that include faith-based leaders, lawmakers, all kinds of multidisciplinary other participants, as well as representatives of the public, to decide how we want to live and how we want to die, and to not only have guidelines that are written somewhere, and not only have physicians, individual physicians, responsible for it, because that leaves them too much in charge and their own interpretations, right or wrong, too much power in individuals' hands. We also need to have extremely transparent structures and procedures in hospitals that allow patients and their loved ones to access these structures immediately, because you know, as your loved one is struggling for air and writhing in the bed in terrible pain, you're not exactly in the best position to be advocating and to be trying to figure out how the system works. And if anybody was supposed to be competent at it, it's someone like me. So I think it's incredibly important to make it a very high priority so that other people have it a little bit easier. We also, I just wanted to add one sentence. I also don't totally hold it against that physician particularly. I think that what he said reflected where he was at. My studies, my faith, my license. He didn't have enough training. His faith somehow did not offer him an integrated view of how to deal with end-of-life care without it being killing. And his license, he was afraid to lose it if my mom would stop breathing, if he gives her something. And it is our responsibility to make it so that the people that we put in charge of such responsibilities as physicians at the end of life, or physicians in general, that we also provide all of those other things in place for them to counter those potential risks that their jobs involve.
Thank you.
I think that's, thank you for sharing that. And I think I see a direct lesson there for the Nuremberg Code, in the sense of, as you mentioned, it was written by lawyers and as a legal decision, and oftentimes the worst perpetrators of dehumanization are the doctors themselves, as we saw from the presentation. So similar to your story, you need third parties to create moral outrage and policing things. You need committees with lawyers and religious leaders and laypersons. But also there's a deep psychological reason for that, which is that whenever people do something wrong or evil, it always feels good. It always feels like they're doing good. So it's very hard to find someone doing something evil, like a psychopath, like a Bernie Madoff or something, you know? Scheming and thinking deeply and then enjoying watching people squirm. That's like very small percentage of humans. Most people, like the Germans, like this doctor who didn't really think very much, we're doing things because they thought they're doing the right thing. So our sense of conscience is often the worst guide to whether we're doing something evil. So a third party can be a corrective, and lawyers are often take that role in the clinical realm. Also, evil, or what people often call sin, is very ordinary. It feels very ordinary. And my favorite example of this is the poet W.H. Auden, who was teaching kindergarten one day, and he went up to the kids and he said, "Hey kids, what does the devil look like?" And they were like, oh, you know, he has big horns and he's really scary. He said, no, it's me. It looks like me. And all the kids got scared, and, you know, they didn't hire him again next year. But the deep philosophical, psychological point is that when people do things that are wrong, they do them by a little bit. They take a little bit off the edges. They cut corners. They protect their own ego. They find plausible deniability in their community, with the people they're interacting with. And those are all the small things that wind up creating the kind of things we were hearing about today. And self-deception is a deep part of human nature. So all those things are really why we need third parties to critique. Yeah.
Right, and structures that enforce accountability, you know.
So I need to say how sorry I am that happened to you and your mom at the end of her life.
Thank you.
What a terrible, terrible thing to have to be part of.
True.
And there are solutions. So I developed and ran the Clinical Ethics Consult Service at Montefiore and Einstein for 35 years. Early in my practice, a woman decided she did not want to be intubated, and that was coming up. And we all agreed, and her family agreed, and we brought in palliative care. And her primary physician said to her, and when you're gasping for breath, won't you want us to intubate you? And the palliative care person said, of course you won't be gasping for breath. We'll control your symptoms so you die comfortably. So we can do that now. We can say to families where there's conflict, talk to me about that conflict. Sit. I have a little acronym. STADA. Sit down. Get everybody in the room, the family, the daughter, and say, what would Mama want? Or what does Mama say she wants? And then tell me about Mama if Mama can't. What are her values? What would she want? Admire. Thank you for coming and helping us make this hard decision. And then finally discuss the medicine and ask what should happen. And that happens openly and transparently, run by bioethics, in very close cooperation with palliative care, open to everyone, documented in the chart. Keep the lawyers away from the process. Lawyers don't do well playing roles in which the values of the patient and family and not the needs of the hospital must be paramount. I'm a lawyer. Keep the lawyers away from hard bioethics issues. But this should never, ever, ever happen. And I think in American hospitals, big teaching hospitals now, we've made it not the norm, but an aberration. But how hard for you.
Thank you so much for sharing that story, first of all. And I think that one of the points that we can take away, one of the lessons that we can learn is that, you know, we need to do a better job of educating people, not just on step one from a medical perspective, you know, first you intubate, then whatever. We need to work on, you know, their moral ethos that's going to guide them in situations like that. And so
I have to interrupt you.
Go ahead.
We don't want the moral ethos of the doctor to guide what happens.
Exactly.
We don't want that.
Right.
We want the moral ethos of the patient and family to guide what happens. Right. And once some people who do bioethics swoop in and announce what should happen, I don't do that because I'm not the one whose values matter.
right.
Exactly.
So that doctor should not have been in a position to enforce his values on the patient and family. Sorry for interrupting.
No, feel free. That's fine. I was going to address this question to Ira because he's a medical educator. Yep, Ira, it's on you now. So we do have to educate physicians, and we do have to talk about this. And 99% of the time, when I speak to anybody about this topic, they assume that I'm going to talk about Mengele, and they assume that I'm going to talk about medical experimentation. But as we've just learned, there's a lot more to this field than just medical experimentation. And so in the interest of kind of, what can we learn? What can we do with these lessons? Oftentimes in medical schools today, the Holocaust is only explicitly mentioned in the curriculum when we're talking about the Nuremberg Code. So are there ways that we can use these lessons as we're educating, future generations of leaders in healthcare, and whether those leaders are going to be, physicians, whether they're going to be nurses, whether they're going to be public policy makers, whatever it is, what is our responsibility from an educational perspective, and how can we draw on the lessons of the Holocaust?
Yeah, so this is I think the hardest question.
You're welcome.
Yeah.
You're welcome.
And I'm sure whatever I'm going to say, we're going to have comments on, which I think is important too, especially since we all have a lot of experience, and even if I may have an answer, which I'm not saying I do, but even if I have an answer, the answer always should be informed by consensus and community. The one thing I do want to say, though, in terms of medical ethics in general, is there is a collaborative care team, and there is a medical provider-patient relationship, and that gets really tough and really tricky, right? Because in one respect, patient autonomy is a first among equals. However, physicians also have a professional and a personal moral integrity that they need to come to terms with as well. If they always subjected themselves to the whims of patients, and I'm not saying they are whims, but what they perceive as whims, that's also not going to be a productive relationship as well. So there's always that balance between being authoritative and not authoritarian as a medical provider and as a physician. But with regards to the Holocaust, so this is the now what question. Great, we know that this is important. We just had, an hour and a half? 2 hours? 2 hours on recognizing that this should be taught. The question is where? So medical schools in general, they're professional schools. They teach competencies and program objectives in order to make someone clinically proficient in order to be able to do their job well. They don't have a lot of time really invested in teaching of history or theology or philosophy. Not to put Omar on the spot, but I'm sure there's a reason why you got an MTS and a Ph.D. in addition to your MD degree, realizing maybe that the MD degree wasn't going to give you the philosophy and the theology that you needed. So with regards to what you can put into a medical school curriculum, you can't just add and you can't just expand and say, oh, this is important, this is important. We're kind of relying on the fact that students will be self-directed in the respect of we'll teach them certain clinical and medical competencies, but they should be able to be well-rounded individuals who care about values and so forth and whatever. What you could do, though, is look at the Holocaust as not a topic-oriented subject, but setting a contextual frame for a skills-based orientation. That also gets difficult. The reason why it gets difficult is because there's two types of people. Well, I'm sure there's many, but I'll put it in this frame. There's two types of people that it's very difficult to learn from. The first are moral saints. When people are so good that you can't relate to them, it's easy to say, well, that is not me. That's great, but there's nothing I can really do about it. The second type is the moral deplorable. Is that person is so bad that I don't need to learn anything from that person because that person's not me. Now, Tessa did a really good job showing that learning about the Holocaust shouldn't be in the frame of moral deplorables. There is a relatability there. But then the question is, are we just teaching the past, or are we teaching a frame to talk about the present and the future? So, I have 3 places where I think it could fit really well, which isn't necessarily the clinical frame, but I do think your casebook would fit the clinical side of education. But in how the physician or any medical provider could then look at his or her role as a professional in social context or in social discourse. So the first is, and I'm not going to mention it a lot, but the whole genetics, right? Genetic engineering and genetic technology today, even if it's very different in terms of the methods and the science of the eugenics movement, the social implications and the philosophy and the methodologies used to think about the issues of genetics, we've been thinking about that for a very long time. So if we looked at the Holocaust, or what led to the Holocaust as a frame for how people were responding and asking certain questions, then in your genetics courses in medical school, you can not have to start from scratch of, oh, how would you think about it? You can look at what's already been productive, or learn from history in order to look at the present and the future. The second is with social media. And I know that sounds crazy to talk about it in a medical school, but I think especially today, it's actually quite important. So today we have this issue of our news and our information is very democratized, which means that no longer do people necessarily go through newspapers or specific news channels, but they get a lot of stuff on the internet. And the onus then becomes on the viewer of what is true, what is alternative, what is this, what is that. I mean, I can go on forever, but you get my point. And we're having a lot of struggles here understanding the value of veracity, or the responsibility and accountability of being knowledgeable in certain areas, not only for my own personal knowledge, but how do I talk to a patient who's read a bunch of stuff on the internet? Right? In the 1930s, there was also a new media that disseminated information democratically to a public, where the public also now needed to be responsible somewhat of knowing what was facts, what was news, and what was political ideology. That happened in Germany in the 30s. The radio was used as an ideological tool to push the party, right? So if we learn through history to know how information is disseminated to the public, so we can respond to it when our patients come and say, I got this off the internet, that's also a good frame, both historically, but to understand context and skills. The third is the issue with regards to the medical healthcare system at large. Today, as much as we love talking about the patient-physician relationship, and it's a great relationship, I'm not bashing it. Not as great as, you know, my marital relationship, but it is also sacred. Is that relationship is being eroded as much as we want, as much as we're saying it's a value, by government, insurance, economics, and the professionality of this patient-physician relationship. That's a problem that we're all trying to deal with, of how do you not dehumanize when you only have 12 minutes to talk to someone and you got to use your computer to write everything down and everything else. That also isn't new. That happened in the Weimar Republic. There was an erosion of the patient-physician relationship because the way healthcare was disseminated, the influence of insurance companies in determining which patients could see by which doctors and so forth, how things were paid for, that if we can learn through history of how to approach the present and future, then the Holocaust becomes really relevant. It's not a category unto itself that, oh, become a doctor and also learn this, but it allows us to say, how can this make us better doctors? So that's how I think it should be integrated in a medical school curriculum.
So I'm sure everybody wants to respond to that. However, in the interest of time and making sure that we have some time, yeah, I'm sorry, but I have to also manage the clock here. I'm sure all of these lovely people would like to speak to you. So I am going to ask for your final thoughts on this topic. I originally had a question I was going to ask you. What you guys are going to say is way better than what I would ask. So basically 70 years after the doctor's trial